God, how's that new laptop? The open up my screen. One second, guys. Okay. All right, you can see my screen. So, right. Now you can.
Yes.
Thank you.
We don't see the, okay.
You see it now?
Yeah.
Thank you. Sorry. I don't know. I guess after a while, a Mac computer gets old. It's not that old though. Anyway. Okay. Let's go to the next slide. Nice and slow here. Yeah, that second, guys. Going on here. All righty. Can you see this? Yes, I think you can. All right. So, Dr. Zawani, this is a tracing that was obtained on, I think this was obtained on a Zeo patch. And as you can see, this is a heart rate at 254 in the morning. So what do you make of this? Do you agree with the artificial intelligence interpretation of this tracing? And then if so, yes or no, and what is it, and what would you do about it?
Yeah, so looking at the tracing, I see that with the first beat, the PR looks long, and then I think probably it's this. It's like maybe 40 milliseconds longer in the second one. Maybe I'm wrong, and then yeah, and then there's the third one like dropped. So yeah, and then if we go to the last beat on the first tracing, then we can see just a P wave without a QRS again. Yeah.
All right. What do you make of like this series here?
So that one also we can see again. So it's the PR interval progressively gets longer, and then you have a drop beat. So I think yes, I'll agree with the second degree AV block.
Which type?
Mobitz I, yes.
So since you brought up the term second degree.
Oh, sorry. Yeah.
Okay. So what are the three? There are three types of second degree block. So there's Mobitz I, which is prolongation in the PR interval with a dropped
yes.
beat. What's Mobitz II?
So Mobitz II, you just have a drop beat without a prolongation of the PR interval preceding that.
And where is the block typically thought to be in Mobitz I versus Mobitz II? What level of the AV node HIS system is Mobitz I versus Mobitz II?
So I think, let's see.
So Mobitz I is usually at the level of the AV node, and Mobitz II is more commonly at the his Purkinje system. It's not 100%. There are patients who have Mobitz I in the AV in the his Purkinje system and Mobitz II in the node, but generally, on average, most of the time, Mobitz I is considered to be AV nodal issue, and Mobitz II, the level of his Purkinje is there. And there's sometimes people call a third type of second degree block, which is 2-to-1 conduction. But 2-to-1 conduction really is either Mobitz I or Mobitz II. It's just you can't tell typically on a surface electrocardiogram, or you need other beats to inform the diagnosis. And so, so typically people will say there's Mobitz I, there's Mobitz II, and then there's a 2-to-1 block. And in this case, we have Mobitz I. So this is a 15-year-old who's complaining of palpitations. This is a recording obtained at almost 3 in the morning. So what do you think, Tarek? Would this concern you, this observation? Would it not? Anything you would do further about this or to evaluate this?
Yeah, so I think we'll assess the patient. So I know with the patient complaining of palpitation, probably a small evaluation would be appropriate. So just to check if the patient, the troponin, I think I'll want to see that just to make sure that the patient does not have any.
Why would you want a troponin level in someone with palpitations?
I think the reason would be to see if there is any ischemia.
So, right, but palpitations is different complaint. Ischemia, if someone were complaining of chest pain, right, I would be more concerned about that. Although, again, you know, we know that coronary disease in children, with the exception of genital anomalies, is pretty uncommon, right? So I would not actually get a troponin as an evaluation of palpitations. What I'm trying to get at here is that, you know, Mobitz I during sleep is a normal finding. And I'm sure all of you, when you review the tele on the patients in the ICU, you've observed this on occasion, patients. One of the nice things about this tracing is the manner in which we see sort of grouping of beats. You see how we have like 3 beats conducted, then a pause, 3 beats, pause, 4 beats. This is also highly characteristic of Mobitz I block. So Mobitz I block when you're asleep is not generally a worrisome finding. It's a normal observation seen in people when they are asleep. So generally speaking, when I see a single dropped P wave during sleep, I don't get particularly bothered, even if I don't even see PR prolongation. Of course, every situation has its own particular details, but generally, if I see just one non-conductive P wave, it's not especially worrisome. It's really when you start seeing more than one. But in this case, I think we quite clearly and you correctly identified this to be Mobitz I block. So we would generally not be too bothered by this. So this observation in a person with palpitations would not be something that would, in my view, warrant anything else to do. But so it's a kind of a normal finding.
Thank you.
Thank you. All right. This is a 4-year-old with a large perimembranous VSD, and he had a VSD closure with tricuspid valvuloplasty 3 months ago. And I want to give a shout out to Dr. Savli, who is this pediatric cardiologist in Vietnam, who is kind enough almost on a daily basis to send me tracings, which I typically see as I'm waking up from bed at about 5 in the morning. And he always has very interesting questions. The LV function, I'm told, is good, and the LV is dilated. And so the question I would have is, first of all, why is the LV dilated? Let's say 3 questions. What is the rhythm? Why is the LV dilated? And the real question that Dr. Savli wanted to know from my perspective was whether or not he would place a single or a dual chamber device in this patient. And I see our friend Mahmoud is here. So Mahmoud, First question is, what is this rhythm that we're looking at?
Good morning.
Good morning.
So the p-axis, so it's positive in lead 1. It's also positive on AVF.
Mm-hmm.
It looks like a sinus rhythm.
Agree with that. It's sinus. And what else can you tell me about the rhythm, though? So I would agree the atrium is in sinus rhythm.
And then the axis looks like a normal axis as well.
Okay. What do you think about the conduction? Dr. Savli obviously is worried about the conduction because he wants to know about a pacemaker. Do you agree with his decision, or?
The PR interval looks to be prolonged, and it is progressing from a beat to another one.
So why don't you look at this rhythm strip here? I think it's easier to see what the relationship of the P waves to the QRSs are, or if there is in fact a relationship at all.
So the RR interval looks normal, looks constant. So it's about 1, 2, 3. Yeah.
So I'll rephrase that to say there doesn't appear to be any RR variability.
Yes.
Okay, I agree with that statement.
Yeah, the P wave, there are P waves, like say on the long strip, the second QRS, it seems that there is a P wave between the T and the QRS.
This here you're talking about.
Yes, yeah.
And so you know, one of the things you always want to look at is is there a consistent relationship of the P waves to the QRS?
No, there is no.
There is not, right? I mean,
So
here
looks
like we have a long PR of almost 400 milliseconds, then we leave it longer, and then here it's short. It's like all over the place. So is there any relationship between the atrial depolarization and the ventricular?
No.
No. So what would we call this rhythm?
Complete heart block.
Right. So this is 3rd degree complete heart block. Great. Okay. So we have a 4-year-old who has a complete heart block. So you got the first question. Great. Second is, why would the LV be dilated in somebody who has, so presumably his heart is repaired. Dr. Safley said the VSD was nicely closed. Tricuspid valve was repaired. Presumably there was, for some reason, tricuspid regurgitation. So why would somebody in complete heart block potentially have dilation of the heart?
Aside from cardiomyopathy?
Yeah, well, cardiomyopathy would be a good reason. He could have cardiomyopathy, although to my knowledge, we don't believe this patient has it, or Dr. Savli would have told me that, I hope. The reason is that when you have a very slow heart rate, you know, there's only 2 ways to maintain your cardiac output, right? One is your heart rate, and the other is your stroke volume, right? Heart rate times stroke volume is your cardiac output. When you are in complete heart block, you can't really increase your heart rate very much. And so typically you'll see dilation of the ventricle as a compensation mechanism or compensatory mechanism to bradycardia. You see dilation of the left ventricle. And so it's very common to see LV dilation in people with complete heart block. And there are, in fact, in the present newer recommendations for pacemakers, the size of the ventricle is one of the factors to consider when considering placing a pacemaker in somebody with complete heart block. So does this patient need a pacemaker? I mean, we're now 3 months out after surgery. Patient generally feels well. Why would we put a pacemaker? I'm going to tell you the answer is that we do need a pacemaker.
Sure.
Do you know why we need a pacemaker, though? Even though the patient feels well, looks well, you know, has some dilation, but it's otherwise doing okay.
So I would say 2 things. So the left ventricular dilation, especially if it was shown to be progressing over time, and then the risk of arrhythmia, ventricular arrhythmia with left ventricular dilatation.
Well, you're right. I mean, the real answer is that yes, you are at risk for life-threatening Stokes-Adams attacks with VF, VT, and VF if you don't pace somebody following congenital heart surgery. So we've talked about this in the past, but it's been a while since I've mentioned this. But, you know, in olden times, like in 1970, when it was really hard to put a pacemaker in people without it getting infected because they were very large, and even adults had to have them placed epicardially a lot of the time, pacemakers, it was still considered okay not to put a pacemaker in somebody who we would today think definitely needed one. And that was because the risk of pacemaker insertion was still fairly high. So you could actually look at the natural history of people who had heart block following congenital heart surgery. And what we saw was that at a year out, about 50% of patients died who had complete heart block following congenital heart surgery without a pacemaker, whereas the incidence of death in people who had pacemakers was essentially zero. So based on those old data, we now feel that anybody with postoperative heart block gets a pacemaker. And we usually would place such a device in the first, usually after about 9 to 10 days. Most of the studies on this have suggested that by 9 or 10 days, there's a very small incidence of recovery at that point. So if you do not have recovery of your conduction by about post-op day 9, you have like a 97% chance of it never recovering. Now, I assume that because this patient is in Vietnam and maybe because resources might be limited, maybe they give patients longer period of time of observation, which is why we're a full 3 months, right? In the United States, we would never allow somebody to go 3 months following this type of surgery with heart block because we would be concerned about the risk for a problem. So Dr. Savley wanted to know whether I thought this patient would benefit from a single or a dual chamber device. So I'm going to phone a friend here, Mama. You did a great job. And let me see if maybe Dr. Barris, could you comment on whether you would consider putting in a single or a dual chamber device, and what would be the benefits of one versus the other?
From what I recall, when someone's post congenital heart surgery, we usually do dual chamber to preserve cardiac function. But I think we've said that if you have congenital heart block, that you could probably get away with just a single chamber. And the benefit of that is I think you can do single chamber via mini thoracotomy, while I believe dual will need sternotomy.
So I agree with most of what you said. What I would say to you is, after congenital heart surgery versus not, it really doesn't make a difference. In other words, the present, why you have heart block isn't always that important to whether you get a single or dual chamber device. It is in that your hemodynamics are very important. So if somebody, so just to give you some historical perspective, up until about 15, I'd say up to about 20 to 25 years ago. So we're talking about like the early 1990s, late 80s. It was actually fairly hard to put an atrial epicardial lead on patients. There was the present leads that you see our surgeons use all the time, these Medtronic steroid-eluting leads with the 2 pods that you see on the X-ray. This was actually a relatively new device that came about in the early to mid 1990s. And you notice it's exactly the same device today. That model has not ever left the service for 25 years. And the reason is it's an outstanding device. And prior to that, there were no bipolar epicardial leads. And so, in fact, when I was a fellow in Boston, they published, my friend Mike Epstein, I think, was on that paper. They published a series. What they would do in Boston to get that bipolar pacemaking leads in was they would take an epicardial lead, an endocardial bipolar pacemaker lead, and then they would lay it on the surface of the heart, and they would ask the surgeon to imbricate the tissue around that lead so that they would have sort of a jimmy-rigged endocardial lead being used as an epicardial lead. And the reason for that is because they really only had these so-called screw-in electrode leads, which were basically unipolar leads and which were unfortunately associated with very high incidence of high thresholds and so-called exit block. So it was very, very common in that time period to put in just single chamber devices, ventricular pacemaker. Turns out that patients did very well. It was very uncommon that patients didn't do well with just a single chamber device. And pacemakers at that time didn't even have the fast heart rates that they have today. So you would sometimes send a baby home with a heart rate of 80, which of course today we would say is too slow. But patients did fine like that. Maybe it wasn't optimal, but they did fine. So I would say that the most important reason to place a dual chamber or a single chamber would be what is going on inside the heart. So this particular patient had a tricuspid valvuloplasty. So I would say that in my mind, my decision to put a single versus a dual would be based on how much AV valve regurgitation there was after this repair. So if a patient was left with a lot of tricuspid regurgitation, having asynchronous V pacing would probably worsen the tricuspid valve regurgitation, whereas having AV synchrony could have a meaningful impact on improvement. When children have normal ventricular function, the actual impact of dual chamber versus single chamber pacing is not very large in terms of cardiac output. So it really is to a large degree based on on what the hemodynamics are of the patient. For example, I follow a young man who was a VSD coarctation. He's a teenager. To this day, he still has a single chamber pacemaker and he feels fine. And I actually had to upgrade his device about a year or two ago. I took a venogram and saw that the vein was open, and I elected to not place a second lead on the theory that all of these leads eventually break. And so because he was doing so well with single chamber device, I decided to continue it that way. Probably at his next change out, I will change it, because the other thing that happens as you age, of course, is your heart stiffens, your end diastolic pressure rises, and you can end up with, so the impact of dual chamber pacing in terms of your cardiac output is enhanced. So the bottom line is there isn't really a right answer about single versus dual chamber. To some degree, it matters how good the surgeon is at placing these leads. And then the other issue is whether it's really necessary. And I am generally a minimalist when it comes to these types of things. I probably would recommend single chamber, but the one thing that's giving me pause in this tracing is that the P waves, they kind of look like he has right atrial enlargement, right? I mean, they're pretty tall P waves, very pointy. So it would make me a little nervous that maybe there is this tricuspid valvuloplasty wasn't spectacular. Maybe there's a fair amount of TR still. So I would probably, in this case, just based on the ECG, recommend a dual chamber device. But anyway, those are the sorts of ways we would think about this type of case. So, okay. Sorry about that. Let me a little out of order here. Sorry, guys. Sorry. Okay, sorry. All right. I just want to find this tracing here. Okay. So this is another tracing that Dr. Savli was kind enough to share with me. And this is what I was told. This is a 12-year-old with hypotonia of the lower extremities, palpitation, no syncope. Echo showed a normal heart with some LVH, and the presenting potassium is 2.8. So I'm going to ask Dr. Bonsall if you have any thoughts about this tracing.
Good morning, Dr. Bass.
How are you, Dr. Bonsall?
Good, thank you. So it looks like sinus rhythm regular,
Mm-hmm.
and does maybe meet the criteria for LVH based on the voltage for V5.
I would probably agree with you, although Dr. Arnon might disagree, but yes, I agree. Dr. Arnon has never seen an LVH in any EKG.
The T waves are pretty flattened everywhere. In fact, yeah, they appear flat in 1, 2, 3. And then in V5, V6, they sort of appear inverted. And that could go in V5, V6, that could go with the strain pattern in case of an LVH. But yeah, so I would call like flattened T waves.
Okay. Any other observations? What do you think about the QT interval, though?
Give me one moment.
I'll give you 2.
It looks prolonged. It looks prolonged. Let me see. Almost like 15 boxes. 15 small boxes. I'm just doing the calculation.
Go right ahead. I'll even give you 3 minutes.
Yeah, it's coming out very high. I'm getting like around 700.
Yeah, I mean, I'm not sure it's that long, but it is definitely long, right? I mean,
Yeah.
and we talked about this rule of thumb. Dr. Ackerman shared with us that if the T wave ends at more than half of the RR interval, that's generally a sign that the QT interval is prolonged. So, so do you have any thoughts on how to put all this together with the hypotonia of the lower extremities and this low potassium and this sort of long QT interval? First of all, what would you do if you saw a patient like this? What would your first move be? The patient is, aside from the hypotonia, the patient basically feels okay.
Does the patient have any muscular dystrophy?
Does he have muscular dystrophy? Is that what you asked? Not to my knowledge. Sorry, that noise is pretty annoying.
Echo with normal heart. So you already got echo. I would check other electrolytes also. Calcium also. Correct electrolyte abnormality.
Well, you definitely know you have one electrolyte abnormality.
Calcium also. I want to check calcium.
Okay, I don't know what the calcium was in this patient. Excuse me, I'm going to close my door. Hopefully, we're not in the middle of a fire right now.
Yeah, I would check calcium and then replete potassium. Correct if there are other abnormalities.
Did you say replete the potassium or replete calcium? I didn't know what you said.
Replete potassium. I don't know what the calcium is.
Right, you would definitely replete the potassium, right? Because potassium hypokalemia can prolong your QT interval, although this is quite long. And when I saw this, what I really thought about, is this diagnosis of hypokalemic periodic paralysis, which I've seen one other case of, which is characterized by episodic severe muscle weakness, which is triggered by exercise and is associated with low potassium levels. And there are apparently 2 types. One is a channelopathy type, which is characterized by a mutation in calcium or sodium ion channels, and it primarily affects skeletal muscle. And then there is a acquired type, which apparently can be seen in patients with hyperthyroidism. It's very rare, 1 in 100,000 patients, and it's much more common in males than females. Interestingly, it's more prevalent in Asian patients, and Dr. Savli is coming from Vietnam, so I assume this patient is Asian. Apparently, an EMG may be useful to make this diagnosis. And typically, the treatment is oral potassium supplementation. And so we would probably recommend some oral potassium. If the patient is basically feels okay and is not having an acute arrhythmia, I think oral potassium would generally be safer than giving IV potassium. You never really want to give IV potassium unless you really need to, because of the risk of problems associated with overdosing that. As I often say when I'm rounding in the ICU, I have never seen a patient have a problem related to hypokalemia. I'm not suggesting it can't happen, but it's very uncommon. I have definitely seen patients have problems from iatrogenic, too much potassium. So I think giving it orally is always safer if you can. Apparently, patients with this are given carbonic anhydrase inhibitors, and apparently the mechanism of benefit is not well established, but acetazolamide is a common agent used. And then, of course, as we would expect, potassium-sparing diuretics like spironolactone. The only one patient I ever saw with this, I think we were treating him with spironolactone and potassium. And interestingly, on that combination, had a normal QT interval. Now, I don't know, Dr. Savli basically told me, I'm sorry, I'm going all over the place. Dr. Savli told me that he felt this was just some kind of a cardiomyopathy with long QT syndrome, which it may well be, but I just thought it's an interesting tracing and a possible diagnosis to sort of tie in the lower extremity weakness and the low potassium. Be interesting to know if with potassium supplementation, if there was an improvement in the lower extremity weakness. Okay, this will be our last one today. This is a tracing from Twitter. This is Dr. Mejia, who is an electrophysiologist in the Dominican Republic, and she posts a lot of interesting tracings online. Here's her insignia. This is an asymptomatic 40-year-old who comes for the first time to our clinic. This is just a quote from her Twitter piece. Family history of sudden cardiac death. Brother died at 30 while sleeping. What would be your next step in management? So why don't I ask Dr. Let's see here. I want to ask Dr. Kong what her thoughts are on this tracing.
Good morning, Dr. Pass.
Good morning. This is one of the last times I'll be able to ask you an electrophysiology question, because you're going to become an immature and you'll be uninterested in these questions.
And that's not true. Cardiology board's coming up in November, so. I mean, it looks like only the precordials are included, so I see that that's probably where the important information is included.
I assume so, yes. This is the exact tracing that Dr. Mejia posted. So she didn't think it was important for us to see the limb leads, only the precordial leads. She's leading the witness, as it were.
It looks like it's likely a sinus rhythm, or my QRS is, I mean, initially when I saw the clinical vignette, I did kind of jump to the J point and the T wave. It did in V1 look like the J point was slightly high, but not like an obvious brugada pattern. And it's not really, yeah. And nothing else that stands out to me in the precordials. I think I would probably do a procainamide challenge.
Yeah, I think so. I mean, this is actually sort of looks like a type 1 brugada pattern. It would not qualify as such because the ST elevation is not adequate. But if you imagine that this was a little bit higher in the ST, yeah, so you could do a procainamide challenge. One of the things that people talked about online as an answer was placing modified precordial leads. You know, if you put these higher V1 and V2 leads, you can sometimes identify the brugada pattern that you would not normally see with the standard V1 and V2 position. So the first step when you have a patient who you think might have brugada, before you would go to the step of doing a procainamide challenge, would be to just do higher V1 and V2 leads to see if you, or so-called modified precordial leads, to see if you have a more obvious brugada pattern. But yes, we would do that. And what would you, if you were in Europe, is there anything else you would do other than a brugada challenge? I mean, a procainamide challenge, I'm sorry.
Oh, yeah, there are other.
What's the agent they like to use there? This is an extra credit question here.
I can't
It's called,
remember.
Ajmaline. So there is a sodium channel blocking agent called Ajmaline, which is not available in the United States, which is apparently much more potent and makes the sensitivity of the testing much greater than with procainamide. But yes, so typically we would, so you would do the modified precordial leads, and we would then do a procainamide challenge and give, typically we give a gram over like 15 minutes, and then watch the electrocardiogram over that time period, and usually for an hour or so, to see what happens to the ST segment. But this history is certainly very suggestive, and the pattern here, although not being really fully Brugada, it's definitely abnormal enough that we would for sure be concerned. So, and I think with that, we'll stop for today. Thanks, guys, and I will see you in sign out in just a short while.
Thank you.
Be well.
Thank you.
Thank you.